So as you know, Ibrutinib was approved several years ago for patients with CLL who've had prior treatment. It also was approved for initial treatment if patients had deletion 17p, but that's uncommon at presentation. Because of the RESONATE-2 trial, it very recently received approval for initial treatment of patients with CLL. So that really broadens our ability to use the drug in patients as upfront therapy. With an FDA approval, of course, it's much easier to obtain it for a patient from an insurance perspective. And so in our practice, of course, we're largely doing clinical trials. That's not as relevant. But for a patient treated in the community, it's all about what they're able to obtain as well. And I think we've seen with the approval in the frontline setting that it's quite easy to access the drug for an appropriate patient. So I think in our treatment algorithm overall, it's really being integrated in, whether in the context of a trial or in standard practice for pretty much all patients. It gives you another very good option when you're making that decision about what's most appropriate for that individual patient that you're making a decision about. So physicians often ask, what do we do after Ibrutinib? What if a patient progresses? And fortunately, that's not been all that common. There is some published data on that, but one has to be very careful about interpreting that data because that study involved heavily pretreated patients who were receiving Ibrutinib. In many cases, they had exhausted all prior conventional therapy and had quite advanced disease. So that's a very different patient receiving Ibrutinib than someone receiving it as initial therapy or even as second-line therapy after, say, an FCR regimen. So those patients didn't do well, and that's not a surprise because they didn't have other treatment options. But for someone receiving it earlier, I would argue two things. First, we do have other treatment options for them, including newer oral drugs as well. And secondly, I think it's a very different patient population. And so I think the progression is going to be much less common. And I think those patients will respond to subsequent therapies, whether they be traditional chemoimmunotherapy or other novel targeted agents. So the idea that you want to hold back your best for later, if you're calling Ibrutinib your best, I think you have to move beyond. There's nothing wrong with using your best therapy initially.